webinar entitled Barriers to Healthcare Access for Families with Children, Access Not Granted. It's a Children's HealthWatch virtual town hall, and thank you so much for making time to attend with us. So let me introduce myself. My name is Avik Chatterjee. I'm a physician trained in internal medicine and pediatrics. I actually clinically see patients at Boston Healthcare for the Homeless program. I've been a shelter-based provider seeing families and adults in shelter for shelter-based primary care, addiction medicine for the past 5 years. And I just joined the faculty at BU School of Medicine about a year ago. And I'm also a board member for the Children's HealthWatch Advisory Board. So I'll be moderating today. I wanted to introduce our speakers, our panelists. So our first panelist is Dr. Diana Cutts, who is Chief of Pediatrics at Hennepin County Medical Center. She's an Associate Professor of Pediatrics at the University of Minnesota. She's also the Minneapolis Site Principal Investigator and the co-lead PI at Children's HealthWatch. I also wanted to introduce Eva Marie Stahl. She's the Associate Director of Policy at Community Catalyst. She helps lead federal policy work to address children's health issues. She coordinates efforts to support community and state partners in advancing a health equity agenda, ensuring the lived experience of children and families are centered. I also wanted to introduce Maureen Bowling. She's an experienced anti-poverty political advocate and expert on poverty with the Results organization. She'll graduate in November of 2020 from the University of Kentucky with her bachelor's in arts and social work as a first-generation graduate and single parent of 3. And finally, I wanted to introduce Rhonda Reed. She's also an expert on poverty at the Results organization. She is passionate and committed to fighting for equal rights for vulnerable populations. So the first thing I wanted to talk about with regard to barriers to healthcare access. We're going to get to the panelists in a minute, but I just wanted to share a little bit. So right now I'm sitting in a shelter-based clinic at the biggest men's shelter in Boston. One of the key features of Boston Healthcare for the Homeless as a Healthcare for the Homeless program and as a federally qualified health center is meeting patients where they are. I think some of our most innovative and effective programs have been going to not only adult shelters where I am now, but my first one of my first clinical sites was actually at family shelters. At that point in around 2014, the number of homeless families in Massachusetts was so high that the state was actually renting out entire motels to put families there. So we'd roll up to these highway side motels with our little suitcase clinic going door to door from family to family. And I think helping families, helping people access healthcare, even in difficult settings, even when their lives are at a difficult point, has been a big part of what I do and what makes me passionate about medicine. So the first thing I'm going to do is I want Eva to address this issue about how families with children experience barriers to healthcare and what are some of them, and then what is the role of racism in driving inequity in the healthcare system. So after I hear from Eva, I'm going to pass it on to Diana. So the first thing I'm going to talk about is the barriers to healthcare access, including racism in driving inequities during COVID-19 for Black, Indigenous, and people of color and immigrant families, the negative health impacts of healthcare access barriers during the pandemic, which have been very, very stark, the current pandemic policy responses and how equity-centered policies can address these challenges on the federal, state, and local levels, and the call to action to support, spur, and inspire change to diminish or eliminate barriers to healthcare access. That's sort of an outline for what we're doing today. So again, first question to Eva. Let's talk about barriers to healthcare access, including racism and driving inequities, particularly during COVID-19.
Sure, thanks, Avik. And I'm delighted to be here with these great panelists today. And Diana, you should feel free to just sort of banter with me and go back and forth on this topic as we talk about it. So, last Friday, there was a report that was released out of Georgetown University. Their Center for Children and Families does an annual report looking at the number of uninsured children across the country, and it lags by a year. So the data actually is pre-pandemic. And what it finds is that we're not doing well. So keep in mind that, and apologies for the background noise, we're all working at home these days. Keep in mind that in 2016, the uninsured rate was really at an all-time low for kids, so hovering around 4.7%. And the latest data from this past year tells us that it's bumped back up over the Trump administration's tenure to about 5.7. And while that doesn't really sound like a lot in terms of a full percentage point, it actually translates to about 725,000 children. So that's a lot. There's a lot of kids. And what's important to realize too is that the number of kids in that cohort are disproportionately children of color, and the greatest rates that we see an increase for are actually Latino children. And so that actually relates to the other part of the question that Avik raised, which is, what we know that COVID is going to be even worse, right? So we know from the May numbers, the unemployment rate, the number of households that are experiencing unemployment, that there's sort of a ripple effect on children, that when parents lose coverage, children often lose their access to coverage as well. We also know that this disproportionately affects Black and Brown communities more than ever. And that's because of, place-based, where you live, where you work, and how you grow affects your health and your access to opportunity. So in terms of how this plays out in sort of the structural racism issues that really were ever present in our systems before the pandemic, are compounded by the pandemic. And so I think we anticipate that we will see further uninsured rates for children of color as we move forward and we gather more data over the year, and sort of little sneak peeks at data across this current year tell us that things are not good, and particularly for children of color, things are not good between loss of parents, disruption in household income, and other factors. But Diana, I'll let you kind of weigh in a little bit more too about some of your research and work.
Yeah, thank you so much. And I'm delighted to be here too. Greetings from Minneapolis, where it's sunny, but about 38 degrees. I think maybe what I want to bring to the conversation as we start this is to kind of talk a little bit about the experience we've had here as clinicians meeting COVID and the way it's impacted our model of care and what we've known. And so I'm just going to sort of tell it as a story. And it comes in several different chapters. I think the first chapter for most of us was shutdown, the shutdown chapter. And for us, that came about on March 13th, that we did something that I'd never experienced before, other than, I believe, a half day during a tornado, when we shut down our clinic to all what we deemed, all visits other than what we deemed essential. Now, essential was kind of in the eye of the beholder. And I will tell you, our view of what is essential care was a view that evolved over time. I think our mindset on those first days in mid-March were that this would be something for a few months, that we would see an epidemic that would peak and would be stressful, but then that it would peak out and get better. And so our mindset of essential was in our clinic, our policy was we saw babies up to age 1 for well child care and immunizations. And I know other clinics were a little more liberal, but we were really concerned about what we didn't know and the concept of safety and protection. And then children who were sick and needed medical care. And we deferred all other visits. And that was a massive effort of calling and notifying people. and we didn't get hold of everybody, and anybody who showed up we saw. But I think this period of shutdown was a new experience for any of us, and we did learn that we could shut things down. That we took a clinic that was generally seeing 140, 150 patients a day, and within 24 hours we were seeing maybe about 30 some. At the same time, we kind of entered this rapid education for providers and staff about how do we do this safely. Because as you might imagine, there was a lot of concern and a lot that we needed to learn. So the debate about what a person needed to wear of protective gear, and did we have enough of it, and who had enough of it, who got priority, how do we train people to put on gowns properly and take them off properly, where were we disposing of things in a way that decreased contamination, how do we teach not just the providers but our nursing staff, how do we protect our lobby staff, what do we do with waiting rooms? We can't have people in waiting rooms anymore. How do we manage that? I think all organizations, and I don't think ours was any different, had to immediately educate itself as quickly as possible. And then did we have the lab support that we needed to keep people safe, including our own staff? We pretty quickly set up a separate clinic for children who had COVID symptoms. And I think many places did, or they did it in other ways where they saw sick people at one time and other people at another time. So the effort to try to protect families and children in our situation was to separate that off. So again, how does one do that? How do you screen at the door? How do you triage on the phone to get people to the right place? And yet reassure people that this is a safe place, that if you're bringing your 3-day-old infant into us, you're in a safe environment. Or if you're bringing a child who has a fever and a cough, you will be handled in a way that is safe and protect you from any potential of additional exposure. So in our system, this period of really redesign and education was kind of the next chapter. And it meant redeploying people in other areas and training people in many systems to do completely different work. So you can imagine that these weeks in March and April were really challenging. As time went on, we started to recognize this isn't going to just be 3 months, this is going to be longer. And our definition, as I mentioned, of essential starts to evolve a little bit, and we start to see children up to age 4. And eventually we see all well children, but we march that out very slowly. And by definition, access was much limited. So providers were going nuts and worrying about kids, and providers began to respond to the situation by contacting families by phone and doing check-ins. And in particular, we were concerned about families with children with special needs. And so we set up a system where we identified those children, contacted them, asked, did they have medication? Did they need refills on prescriptions? Were their children doing okay? How were they all doing with the changes of no school? And how were they coping? Were there other changes in the household that we could help with? Could we help them access food? And we developed some mechanisms by which we were able to connect families to food shelves using courier systems. How was their own health? And we started to take in those calls questions, a lot of questions about should I come in and be screened and how does one do that? And we started to triage that out. And so I think that as we are going through this whirl and trying to define things like how many people can be in the elevator at one time, we were also trying to really leverage in new ways outreach. In here, our OB providers began delivering blood pressure cuffs and doing prenatal care virtually with pregnant women. Over time, we were able to develop a vaccine mobile because we knew immunizations were going to suffer. And so we were able to use a vaccine mobile that could make appointments and see children just for immunizations and some other limited care, trying to meet families where they were at in a safe way. We were able to set up a number of other ways in which we were doing home monitor of patients who had COVID. And we had a special medical team that does that monitoring and uses some medical equipment that's delivered to their home for their check-ins. So I think that in this atmosphere of redefining and then redefining essential care, trying to quickly build new outreach and ways to reach family, and yet we know that many families were struggling for access or hesitant for access, quite frankly. And you know, I think that this was all a very active state. And then for us in Minneapolis, many of you know this was the site of Mr. Floyd's murder. And the end of May, as we were working with all of that, we entered a period where, again, we had to close down. Our city was experiencing unrest around the hospital. And we had experiences where our pharmacies and our outlying community clinics experienced break-ins. One of our clinics was destroyed in the riots. Many of the pharmacies that refilled our patients' medications were destroyed in civil unrest. So we had a new layer come in to our sort of environment that erected more challenges for access to care. And again, we spent some time swirling as to how we keep people safe and allow them to feel like they're in safe space and getting care. You know, I think I want to talk for just a minute about telemedicine, which I think has been an interesting experience for a provider who was maybe starting to dabble in it, but then suddenly, like many of us, very rapid uptake of organizations in trying to set up telemedicine access. And I think our department, like others, really welcomed this and felt that either through telephone care or then pretty rapidly video visits, that this was another way of increasing access in a really safe way. But of course, it has its limitations. So I think we are still on that journey. And our learnings have been that in a patient population where about 40% of our families use English as a second language, virtual visits and telephone, the technology, the need for interpreters, and just the comfort level of it, and the sense that you are in a safe place wherever you are in having what is really considered an intimate, confidential encounter in many cases, doesn't happen easily. And what we have found for our clinic is that the uptake has been slow. And that although it may have been sort of branded as a way to enhance access, I think our experience has been that to some degree that's been true, but in other ways it's increased disparity of access. And we are struggling with that currently.
Thank you, Diana. I wanted to actually ask a little bit about that and a related question, which is that there are a lot of pre-existing policies that are barriers to care, that had been barriers to care even before the pandemic. And I wanted to ask a little bit about how those interact. So one thing I'm thinking about is a change to the public charge rule, which made it that a lot of immigrant families, even if they didn't fall within the category of families that were affected, were afraid to access healthcare because things like Medicaid, because it might be a way in which the government might enact deportation or other forms of discrimination. And so I was curious if how policies like that interacted with COVID-19 to make barriers to care even greater, particularly among the most vulnerable population. There are other populations. There are other ones too, actually. And I do think about telemedicine because if you're already having challenges to access around things like language and so forth, and on top of that, now the only way you can access is if you have reliable internet, and if you have someone who can maybe translate for you if the teletranslator, if that's not working out and so forth. So I was curious how those things interact to make the barriers even worse during the pandemic for folks who are the most marginalized.
Yeah, I appreciate the question, and I'm going to let Eva chime in too. From my point of view, we were already experiencing chilling effect of immigration policy and public charge and the perceived threat that families felt. And that was, families articulated that to us, that they didn't want to come to public spaces before the epidemic. They were really concerned. I think that one thing that the pandemic did was it took some of the sort of social press of that, the headlines of it damped it down. And that I think that the fear still existed. And for some families, I think made them reluctant to access care when they needed it. But I also think there was recognition in the community that this was a time when they were seeing people in their community get sick and die. And that's the reality of the disparity of the way COVID has impacted the population. And our Latinx community has been hard hit here. And I think because of that, a community that recognized its very life was at stake, that the barrier to in-person care, because of concern of public charge, it just got lower on the priority list, quite honestly. And Eva, go ahead, you chime in.
Yeah, I would say that, without a doubt, public charge and the just consistent attacks on immigrant communities over the past 4 years have created just huge problems with keeping families secure, safe, and keeping children healthy, without a doubt. And adding COVID on top of that, which really, if you think about COVID as sort of a big light shining down on all of the inadequacies and structurally biased systems that we operate in that are designed and operate in a way that harm Black and Brown people across our country more than others, it is a real wake-up call. It's also devastating to think about children losing ground, both in insurance, but also in health and in education, and in general opportunity, because they're being denied resources. It's interesting, there were a number of clarifications that were made around public charge to suggest that it is both safe and accurate for the majority of folks to seek out services and not have it used against them in any determination about their status. But it didn't matter. It doesn't matter, because the goal was to create fear, and it accomplished that. And so really, I think as we think about the call to action moving forward, it's about re-engaging community and building trust. So as much as we can open the doorways of coverage, people really are not ready to walk through the doorway. It doesn't feel like a welcome mat. And so there's just a lot of work to do in reversing those trends. And it also really speaks to the importance of some of the learnings from COVID. So you mentioned the issue, Diana, of maternity care and trying to do that care. And we've seen in states across the country that people will are redirecting pregnant people to separate birthing units, right, that are separate, and re-engaging community resources to help people, which is part of the movement to build a stronger workforce at the community level of people who look like their patients and have that same lived experience. And we know that we can get improved health outcomes if we use doulas and community health workers. And we are more inclusive in our caregiving and placing the voices of people that are living these experiences and putting them in charge of that decision making about their care team. So I think that's the bright side, right, of some of this horrificness that we are experiencing. But without a doubt, I think that Avik, you're absolutely right that it is going to be quite a journey to reverse some of the damage that's been done.
Thank you. Now I want to turn to Maureen and Rhonda. I would love to hear a little bit about what it's like to experience the healthcare system during COVID-19. What specific barriers have been, what you're encountering from your perspectives. Rhonda, you can go first.
Yes. So for me personally, for one, I just want to say thank you, and I'm honored to be a part of this discussion. And also, I'm somebody who has been greatly impacted. My aunt tested positive and quickly declined, I would say in early March. So that was like at the start of this when we knew very little about, you know, how this would all play out. And we certainly didn't think that it would affect us this long. But I am a mom. I have a 5-year-old little boy, and you know, he's at that age where they are going to the dentist and getting their preventative care measures, and we weren't able to do that. So I would say early March or April, he started to complain of a toothache, and it was extremely difficult getting him into a dentist to get him to be seen. And then when we would make an appointment, it would get canceled. And then the next appointment was 30 days out, 30 days out, you know, 40 days out. So last Thursday, I was finally able to get him in from April. And he did have a cavity that was going to be just a simple fill that ended up being 2 extractions. So just even me being a part of this and preparing and working from home, and now a sick kid, and it's supposed to be his first year of school. It's really, really, really impacted, but just seeing how something as simple as, you know, him being able to get the proper dental care, and how fast he declined, sitting in that room, seeing this little 5-year-old boy get teeth pulled, is heartbreaking. And even with that, I still feel privileged that I was able to get him in. I do work with families that are impacted greatly by poverty, particularly women that are escaping human trafficking. And a lot of times they have children, and they're not able to access healthcare systems because for one, their main priority is somewhere safe to sleep tonight. So taking their kids to appointments when they're like constantly getting canceled or so far out, it becomes really difficult for them. Also, you know, how can you practice safe distancing when you're, you know, couch surfing or precariously housed, unstably housed? So that is what I'm seeing in my work. And I always try to let the individuals that I'm working with know that, you know, I am more like you than I am different. And we're kind of all experiencing the same place. And I think that that's what this virus did for a lot of us, is show that we are more alike than we are different. And we are all struggling to just cope with it all. So I would say for me, those are like the main things that I'm seeing and kind of experiencing myself.
Thank you. That's really powerful. I appreciate that. Maureen, did you want to share a little bit?
Yeah, thank you so much for having me. I am a single parent of 3, and I'll just speak a little bit about some of the barriers to healthcare that we have experienced as a family living under white privilege. So we have faced barriers to healthcare in every aspect of our healthcare needs, and that ranges from dental visits, eye exams, regular health visits, and our therapy appointments. So some of the consequences to those appointments being delayed because of the doctor's offices shutting down for a prolonged period of time, and then taking a lot less clients and patients are delayed in those regular visits. And as a result, like my children, every single one of them has been affected negatively. My children are behind on their basic vaccines because they can't get in to see their doctor for another 2 months. And we've been trying to get in since before school started in August. And then my daughter was behind on her dental visit, and she ended up having 2 cavities. She's never had cavities in her life. And both my son and my daughter, who my son is 14 and my daughter is 12, suffer from anxiety due to complex post-traumatic stress disorder from some past abuse that myself and they suffered through in a domestic violence situation. So they were not able to access their therapy appointments. And in Kentucky, one of the leading causes of death of early teens and teens is suicide. So for us to miss those therapy appointments, it was very detrimental for their mental health and my mental health as their parent to see them struggling without that service. And then when they did start back up, they offered Zoom counseling, and they have to travel between homes, and their other home is not as secure as my home. So they didn't have a confidential space to be able to share what they were experiencing. And these are just a few of the barriers to healthcare that my family has seen. And to speak a little bit on what I do for employment, I work with differently abled individuals within the community, and they range in age from in their early 20s to their 70s. One of my clients was so terrified to go seek medical care because of a pain in her stomach, that because she was scared of the virus, that she put it off for so long, she ended up being hospitalized. And she almost died, and she's currently still in the hospital, and she's been there for 5 weeks now. And it was from an impacted bowel, which is something that if she had gone in to have treated fairly soon, when the pain first started, it could have been prevented. Instead, she had to have major surgery. It is now recovering as an elderly patient from that. So to see my patients suffer like that and my clients suffer like that has been extremely painful. And I think that just having the space to be able to share some of those barriers as a single parent and someone who has lived experience with some of the safety nets that are offered to people in America, I really appreciate the opportunity to come and share some of those experiences.
Thank you so much, Maureen. I appreciate it.
Can I just pick up on one quick
please.
point that I thought really important that Maureen lifted up too, is that I think you raised a really important point, Maureen, around anxiety and access to mental health services. And I just want to comment on the surge that we've seen, particularly in young adults and in older children in that space. There was, I think, actually out of a researcher out of Minnesota published some data earlier this year. And it's just, we've already had challenges around access to those types of networks. And now, you know, I'm a parent too of 3 kids and one with special needs, and accessing those services, you know, even in the best of circumstances is challenging. But to add these layers, and I think one thing that we just need to say out loud is that everybody needs broadband. one of the changes that are actually one of our teams is seeking is just to be able to bill for phone conversations, because many people can't even have the video conversation, right? So I think that's another structural issue, that disparity in access to how we now operate in this current environment is one not to lose. But certainly it's going to be a growing challenge as children face trauma moving forward.
Absolutely. One thing I want to talk a little bit about, speaking of everyone should have broadband access, is what have been government responses to these challenges, and the fact that there are specific populations of color that are the most affected often. What is the government doing to facilitate access, to improve quality of care in these difficult times?
So the short answer, Avik, as you know, is not enough. So keep in mind that we have not had another COVID relief package from the federal government since early this year. And there has been an inability of Congress to meet the needs of people that are really struggling. We've had a couple of administrative tweaks. So the broad framework is that there should be resources for housing, right, to keep people in their homes. There should be resources for food access to keep people fed. There should be resources for those who are unemployed through cash payments and making sure that they continue to have access to the financial means to stay stable. And there needs to be access to healthcare, because, by the way, this is a pandemic. And so, those are kind of the pillars of what a package should look like. And there have been some positive things that came out through the public. Once you declare a public health emergency, a lot of these things roll naturally from that declaration. So we do know that at least most people in states can maintain their Medicaid coverage through something called a maintenance of effort provision, which means that states cannot change their policies around Medicaid or kick you off. And that's really important. And that is in sort of, it's anchored to the public health emergency. And there have been, the unfortunate part is that there still is housing instability, and rental assistance is desperately needed to keep people in place. And there have been some strides in accessing food stamps, and that we assume will continue to move forward, particularly for young children as a part of their school systems, which is really important. But we know that we need more funding. And part of that is because states don't have the budget to support all of these array of services. If you have nothing that's open, that's bringing in tax revenue, you don't have any funding to support the services that families need. So I think that, we are in a very challenging moment where states are clearly struggling, families are struggling visibly, and Congress is not heeding the call. And our hope certainly is through continued calls to action and pressure from constituencies that we can get more done in the coming months.
Thank you. And I want to hear more about calls to action in a minute, but I want to go to Diana from a practitioner standpoint to talk a little bit about what, from her perspective, would be policies that the government should put into place that will help with access during this time.
I think Eva said it so well. But I'm going to expand a little bit on the access, the healthcare access piece, because I think that as we talk about healthcare systems which shut down the way we've experienced it and talked about it, we also have to recognize that as they shut down, they lost their sources of revenue, and that we have completely fractured the financing of healthcare systems. And we continue to do that as we currently look at what some are now beginning to say may be our second wave, that we do have the benefit of more knowledge and better treatment. And that is going to keep access open. And my sense of access is that systems are trying very hard to reopen, recognizing that, the Center for Medicare and Medicaid released statistics that showed that immunization delivery is down 22% in kids less than 2. screening for development and hearing and stuff is down 44%. Mental health services by their own charges, down 44%. Dental care, which you both talked about, down 69%. Those are programs that cover 40 million children in this country. So we have a tremendous deficit that we are trying to make up at a time when we have a healthcare system which financial base is pretty gone. So the talk that I hear about relief, really without relief, and we're already seeing this, healthcare systems are going to collapse. Those that are most vulnerable, that serve the underserved and serve in rural areas will collapse first, and we're already seeing that. Others will constrict. We're already seeing that. As that happens, there will be more job loss, which means loss of insurance. So we need this relief in a desperate sort of way. And part of it is for the very reason that we talked today, is to ensure access to healthcare, which I feel is in great danger right now.
I'm so glad you raised that, Diana, because I think that it's been particularly hard on pediatric providers, and that it goes unnoticed that these providers that serve large numbers of Medicaid and CHIP public program enrolled children, their well visits are down, as you noted, vaccinations are down. And it puts a child at risk, but it also puts the practice financial infrastructure at risk. And so we need to this is the role of government, is to step in and preserve this public health infrastructure that will be vital to recovery, right? So part of the way out of the pandemic is to have a system at the ready to disseminate vaccinations, to care for children and families as we move forward. And so if we continue to see the types of closures that you're noting, and we don't invest in children, we're going to continue to have incredible challenges in the future.
Thank you. So that sort of brings us to our call to action piece. So I wanted each of you to speak briefly about what people can do, what attendees here can do, what community members can do to try to affect change, to make this better. And I don't know, Eva, if you want to start.
Sure, happy to. So I would say as I sit here as a health advocate, looking to really lift up these challenges and have a specific call to action, it would be for everyday people and everyone in every place to continue to put pressure on the Senate and call senators, call members of Congress and your representatives, share your stories, hold them accountable for inaction, and continue to press for more relief in this unprecedented moment. And remember that it's really about not pitting one need against another, but it's really a robust package that helps the health of individuals, the health of our states, and really moves the country toward recovery. And that every dollar spent on Medicaid is not just about protecting an individual and a household, but it's also about stimulating the economy and pushing us toward recovery. So I would say that that's for us where we are, about continuing to pressure for change.
Excellent, thank you. Diana, did you want to share a call to action for the group?
Well, I'm going to echo Eva Marie. She's nailed it. I think that on a systems level, I would say the relief that we need, the CARES Act, and then the preservation of the ACA. Let's be honest, we've got a real challenge. If that goes down the tubes, we're looking at a lot of people who are currently have coverage losing it. So I would put that out there. And we know there's going to be a strong politic about that that's playing out as we speak. So medical insurance by whatever means. And then I would also say on a sort of community and family level, families seek care. Look for care. Call those offices, bang on the doors, look for alternative sites if you need to, and new models of care outreach that are springing up. Take good care of your children, and remember, we are still in this. Don't let your guard down. I'm sorry to say, maintain your vigilance and protect your children. Get flu shots.
Thank you. That's great. Maureen, did you want to share a call to action?
Yeah, thank you. And I'll just echo Eva and Diana in saying that to call your senators and representatives and speak to them about the needs that we have for the safety nets that are currently in place, and the importance how important it is that we protect those safety nets, and that we also push for increased funding for those safety nets moving forward, especially in the wake of COVID-19. And I really appreciate what you said, Diana, about putting out there for parents to protect their children, because I've had to call 4 and 5 different practitioners to get different appointments sooner than what was available with their primary care physician that they've been seeing since birth. So I think that is very important. The only person that can advocate for your children, or the person that can best do it, is a parent. So I think that that's really important too. Thank you.
And Rhonda, did you want to share something with regard to how you feel like people on this call can help out families like yours, but also families you work with?
Yeah, I think everyone summed it up beautifully, but if I could offer kind of a unique perspective on things we can do is using our advocacy in different ways. I think just sending that constant message in all of our platforms. We are in a very tech savvy society right now, and especially with us all like working from home, but just understanding the power of like our social media networks, and just keeping that message going that this virus one is not over, because I think a lot of people feel like it has subsided because the shock of it all has kind of gone down, but we are still living it, and we see these numbers increasing. But in the groups of individuals that are, unstably housed, they have those food insecurities, and it's not just us dealing with the virus itself, but everything that is kind of like a byproduct of living through that. Just raising awareness, I think, does a lot to kind of keep the message alive that there's still so many of us impacted by it. So I know I use different networks like LinkedIn, and obviously like Facebook and things like that, which, I know sometimes we can look at like, okay, but I think they do a great job with like sending that message to like everyday people, and it reaches so many people. And you are a lot of times able to get resources and assistance in ways that, you didn't even know were there. So I know all of my like local politicians are on social media, and they use their voice, and that's how I reach them. So I think using it that way to like maintain advocacy would be great.
That's really powerful. And Serlin, that may be a topic for another whole webinar around, because people will do this on Twitter. They'll call out a specific person or big company, big entity that you couldn't just do in real life, even with a letter or something. You put it on Twitter, and it all of a sudden can bring a lot of attention to these things. So I also probably am breaking some Children's HealthWatch advocacy laws, but I will say it might be interesting to think about how we can harness social media in innovative ways to do advocacy for our families. So, but yeah, this is great. I really appreciate it. And you've highlighted the variety of ways in which we can advocate local level, the Senate, state, Senate level, the federal government, but also the fact that now it's so complicated because there are judges involved. You have to be aware of who's going to be the Supreme Court justice. There's a lot to know, and social media can be a way to educate people. And obviously, I would be remiss if I didn't also say people should be voting, making plans to vote, making plans for their family to vote. Reaching out to folks to help with that. So that's great. So I
And don't
think
worry, Avik, that accountability is C3 work. You're all set.
okay, great. So I think that we can transition over to the question and answer period. So there's a really great question here, which now people have alluded to, but this Meredith Dodson is asking for us to talk about the intersections of health access, housing, and food insecurity. And where she is seeing housing scarcity and food insecurity rates increasing, and she's curious about the short and long-term health effects of that. So what's the intersection between COVID-19 pandemic, but also on top of that, housing and food insecurity?
I'll speak just in general. As the data is coming forward of the measurement of points of housing insecurity or food insecurity, we are seeing these steep increases that I think are, really frightening because we already have research that links those things to health. And we know that food and housing, among other social determinants of health, are powerful and not well addressed in a one-to-one interaction with a physician and with a prescription pad, that it really takes public policy and communities. I think that would be the other thing I would sort of throw out into the conversation is that we need public policy at every level, but we also need strong communities. And one of the things that I think has been encouraging is to see community collaborations that previously didn't exist come together in really powerful ways that remind us of the power of local communities and what people can share. I think in and of itself, we know it's not enough, but it's a piece of the puzzle. And in some ways, on an individual level, it's a really powerful piece of the puzzle. But we need to, I think the health impact of COVID, as we've described it, has been measured in infection rates and in deaths. But as we get smarter and think long-term, we will be measuring it in other health impacts because the ripple effect is so profound.
I think that's right, Diana, and we'll see it sort of ripple across other sectors, right? So you'll see you'll see it show up in other places, and so that speaks to just the whole problem of how we structure our public policy and our systems to be so siloed. So, a lot of the work ahead. And what's interesting is that in the COVID pandemic, I think what we already knew it was true, but it's sort of accelerated action by loosening some rules and just acting out of an emergent situation. Like, schools play a big role in feeding kids, right? So when you take them out of the equation, how are people fed? So it's really sort of simple but important connections between these systems and the complexity of how that they work with each other, either due to financing or different administrative rules, that really need to be cut through and addressed because families need support and they're interwoven, and they should be.
I'm glad you mentioned schools. I'm going to talk, I feel like as we talk about children, that the absence of school in a family's life is profound.
Yep.
They feed kids, yes, importantly, but they do so much more in terms of family support and structure and the relationships that children have with other adults in a school community, that it's so profound. The socialization that takes place in school that supports children with peers. We've stripped kids of so many things by their inability to attend school. And so one of my hopes is that as schools come back online for families, that their role is, there's been a brighter light shown there for us to remember how vital they are to supporting families.
I mean, they're like a barometer, right? I mean, they're really, and so I think, you know, some of the conversations I've heard too is that, oh, well, we don't know about vaping anymore because we're not there. So it's just sort of as a problem that went away. It doesn't go away. It's just that the school was sort of measuring it for us in a way and helping with interventions. And so when you take it out of the equation, we're losing a lot of information and data about children and their health and their trajectory. And I think it's scary for a lot of families, but for a lot of communities of what we have yet to sort of face moving forward. I think about something, just a quick example is that, you know, schools do screenings every fall. A lot of states have now, they usually mandate these health screenings, and now they're not doing them. So we've lost a tremendous amount of information about how kids are when they're most vulnerable and in a fragile moment.
Thank you. One other thing I'll add is that evictions protections have been so key, and we're really lucky in Massachusetts. So we've had a basically a proactive evictions ban by the state all the way through. I think actually pretty soon it expires in Massachusetts, but it's been hugely helpful. Now there are other bans. So there's the CDC ban on evictions, but my understanding of this is a CDC ban, which is less relevant now it has been less relevant in Massachusetts because we have the more comprehensive state level ban on evictions, because the CDC ban requires some proactive actions and documentation on behalf of the clients. So I think the legal protections are there, but the person has to sort of pursue those protections, which I think makes it a little bit more easier to be evicted and then experience, you know, have that person experience homelessness. So I did want to mention the fact that evictions protections, advocating for more comprehensive statewide evictions bans, because the federal ban is going to be hard to get for a lot of the reasons that we talked about, might be another way to go and advocate and try to do that. Rhonda, you're going to say something about that.
Yeah, I was going to piggyback off of you a little bit with the evictions. So I know that when a family is evicted, it greatly impacts their access to food. So I know here in, you know, Wisconsin, which I can speak to, there was like an increase in food share benefits for families, but if they don't have a home, they don't have anywhere to properly store this food. So a lot of times they result to eating very unhealthy, quick, fast options, which weaken their immune systems. But then also without a permanent address, it takes away their ability to access food pantries. Because I know, like I said, for here, you need an address or a zip code to access our food pantries. So without that, it just makes it incredibly difficult to access healthy food resources as well. So
Oh wow, that's
it's like
so
we don't even think about like how.
That seems like a policy.
Sorry,
I was just going to say, having to have an address, having to have a zip code seems antithetical to the whole idea of the people who would need the most support. So that seems that should change, I feel like. So we have another question in the chat, which is, we talked a lot about health insurance for kids and of course adults, and this person's asking, there's lots of research demonstrating that when parents don't have insurance, even if their kids have it, they're much less likely to have access to care. I think this is relevant for other needs as well. Food, for example, if parents are ineligible, even if kids are eligible, the whole family doesn't get the assistance. Can you talk a little bit more about these benefits, whether it's food, health insurance, from a multi-generational sort of family perspective, if there's a problem with one family member? And, you know, in a lot of ways, that's sort of the way that public charge was meant to work, that it was meant to be that not just that person who's an immigrant was accessing benefits, and therefore that person would have an impact on their immigration status, which is bad enough, but that their whole family would be you know, hurt if that one person accessed the benefit, which is really, really traumatizing and challenging. But any perspectives on that?
Just that's absolutely right? It's we know that when parents have access to coverage, that children often gain access to health insurance too. And, you know, I think that's why policies are really need to be designed in a 2 and 3 generation form to ensure that there's access across the board in health insurance. And while I know less about other sectors such as food or for housing, but I would just make the assumption that, you know, that connection between the dyad of caregiver and child is replicated across other sectors as well, and the strength of that connection and making sure that you would care for the child that you're caring for by making sure that they're well fed, that they're housed, that they have insurance.
I would just add, you know, we learn over and over again that it's very challenging to have healthy children if we don't have healthy parents.
Yep.
And our sort of singular view, you know, the irony that public charge has sort of taken a multi-generational approach in such a negatively impactful way, but we are really struggling to take a multi-generational approach in a positive way, which looks at family units and what they need to thrive as a unit instead of divvying them up into individuals.
That's right.
Yeah, that's really helpful.
I would just lift up one data point that I was sharing at the sort of offline at the beginning, is that there's a new report out of the United Hospital Fund that looks at the number of children in New York City that lost a caregiver to COVID. And, you know, and for Black and brown children, it's 2 times as likely than for others. And it's devastating both from a trauma perspective, but also for reimagining what the family unit and household looks like moving forward, and how we support the entire household in terms of recovery and healing. But over 4,000 children lost a parent, and that's pretty traumatic. And so it's important to remember that element of recovery, that it's not just about trying to plug the holes of now, but we have an entire generation of young people that are affected negatively by this experience, and we need to be thinking about a recovery that's structured for them.
Thank you. Any other thoughts on this issue of maybe Maureen or Rhonda? Any thoughts of what you see happens to families if one person loses coverage, the other person doesn't? But does that also influence the other person? Like, oh, now that my kids don't have insurance, or I don't have insurance, even if my kids do. Or if, let's say, you lose employment, your kids lose that benefit, you could apply for Medicaid, but it becomes this barrier that for them. But that anyway, I'm curious what you think about the intergenerational effects, where if someone's eligible but another person isn't, how does that affect behavior?
Yeah, I have some personal experience with that. When I sort of separated myself from my husband and I lost my insurance through him as a result, I applied for public health services, and the children were available to receive Medicaid, but I was not. And that was very difficult for me because I had a lot of health needs, especially after leaving a violent relationship. And so I kind of had to learn the rules of poverty. I had to learn what I needed to do to qualify for those services. And for me, in processing through everything I had been through, a main road out of sort of the oppression that I was experiencing and not being able to access the services I needed was to go back to school full time. And that was a pretty huge decision to make, coming out of that relationship as a single parent with zero housing and zero income. So people are punished for circumstances that they incur that are through no fault of their own. And luckily, after being enrolled in school, and also part of our requirements are working at least 20 hours a week, I was able to get on Medicaid as well. So, but that took several years to get to that point, and it's just not okay.
That's really powerful. I appreciate you sharing that. So there's one more question, which is that could panelists talk about how they incorporate their community perspective or their own stories about challenges of securing healthcare and their advocacy? So yeah, I mean, I think for me, from a provider, from a physician's perspective, I've written a couple op-eds and other type pieces, and I always include a patient story because it's, I think we know this. Some people are convinced by facts, but a lot of people aren't. A lot of people need the story and that narrative, and it's just, you know, from Maureen and Rhonda, from the stories they've shared, it's just everywhere. It's omnipresent. Every day in clinic, you hear these stories, and so being able to channel them, you know, with permission, obviously, to make positive change is really the way to go. But I try to do that all the time whenever I'm writing.
So I just want to commend the bravery and leadership of Rhonda and Maureen in this space of sharing these stories, because it's scary and it's hard. And it feels like, you know, you could put yourself at risk and the people that you care about, I think, particularly as a parent. As an advocate, you know, I see the effective strategies that Avik mentioned as being really important: to participate in media, to write letters to the editor, to make the phone calls to members of Congress. As a parent of a child with special needs, I also think that there are different opportunities that you can think about too, to infuse your story into how policy is developed, even at the most local level. So, you know, sitting on a substance use coalition in your community, helping your school understand trauma, helping your school understand the need for mental health services, asking questions and showing up as best you can, which is often hard when you're facing health issues, particularly of children that you're caring for. But I think that there are, you know, sometimes small steps. We often think about it as the ladder of engagement, but I think that you find when you're the power of your story and your voice can start to move the needle or change someone's mind, it's really energizing because you do have power. So thinking about the different ways that you can sort of climb up that ladder and make a difference, it is possible.
Great, thank you. I think that brings us toward the closing of our event. Unless Rhonda or Maureen, you wanted to share something about story. To Rhonda, I'm curious what your use of social media might be around stories and sharing them and trying to advocate change with that.
Yeah, really, one way, like I said, that I've really used my platform is to make sure that I'm connected with the leaders in my community. It kind of breaks down this like hierarchy of like accessing them, which sometimes, like when you're just like a regular, you know, citizen, it just feels like, you know, how do I get this person to communicate with me? And I've been really successful with communicating with them and actually having like dialogue and conversation, which has led to meetings and conversations simply through just using it that way. So, I mean, that's just, you know, for me, the way I've been able to use my platform and kind of bring a lot of those experiences and stories to life. But then also, we kind of touched on this like very early, you know, like obviously with this pandemic, we also saw a lot of unrest in our communities. So I've been able to communicate with a lot of our local grassroots organizations that needed further communication with those decision makers and kind of be like a liaison to kind of bring these two groups together. So that's the way I've used mine.
Perfect. Thank you. I think with that, why don't we go back to Serlin to close. But I wanted to thank all the panelists so much. All of your open, honest, and also energizing and motivating comments were really insightful and helpful. So thank you so much.
Yes, I want to also echo that. Thank you all so much. Thank you for the attendees for coming. and listening to the wisdom and experiences and perspectives of our wonderful speakers, Dr. Avik Chatterjee, Dr. Diana Cutts, Dr. Eva Marie Stahl, Maureen Bowling, and Rhonda Reed. You are all just incredible individuals, and I'm so grateful for the work that you're doing on behalf of disadvantaged communities that really need their voices lifted, and you're doing that work. It's not easy work. And so we're really, really grateful for your dedication and for your commitment. If attendees want to stay connected with these speakers and also their organizations, we have their website addresses up here on the slide. So of course, Children's HealthWatch, Community Catalyst, results.org, and the Boston Healthcare for the Homeless program. I also want to, in case people don't know, is that we're really, really excited to let you know that Congresswoman Ayanna Pressley is this year's Children's Health Watch champion, and she'll be accepting the award and giving the keynote address at our fall celebration, which is on Monday, November the 16th, from 7 p.m. to 8 p.m. Eastern Standard Time, 6 to 7 p.m. Central Time. So we're really, really excited and grateful. As you know, Ayanna Pressley definitely stands up not only for her constituents here in Massachusetts, where she hails from, but also for countless others across this country. So we're really, really, really excited just to hear what she has to say and what she is going to share with us that evening. So go to our website at www.childrenshealthwatch.org to register. And also stay tuned for more details on other speakers that will be joining us that evening. The last thing that I would want to say is go vote. I know we're inundated with lots of messages about that. It's on the radio, it's on TV, on our social media, but and people are probably tired of hearing that this is the election of a lifetime. But it actually truly is. Up and down the ballot, so many decisions are made on our behalf. So you want to make sure that your voice is heard. Check with your local city hall, voting board, et cetera, to find out where you can go vote. Of course, mail in your ballot, et cetera. There are multiple ways to engage in the voting process, but make sure if you are able to do early voting, take advantage of it. If you've seen the news stories, even with early voting, there's been record numbers of people going, and it's just going to increase as we get closer to election day. So please make your voice heard. Please go vote. It's really, really important. Many of the programs that our speakers have talked about today, are legislation that policymakers put into place, right? And we want to make sure that they're reflecting the needs of the community, particularly the people that all of us here serve. So please go vote. It's so crucial this year. Please make sure that you do that. And with that, I will say thank you all so much again for coming, and thank you again for our superb, excellent speakers. We really appreciate your time. Thank you.
Thank you.